In the name of the Father, and of the Son, and of the Holy Spirit, one God, Amen. Okay, guys, let's talk about today's topic is about hernia, abdominal hernia. So let's clarify the key points that were misunderstood by you during previous board exams. So take your pens, as always, and papers to make the notes, and let's go. So the vast majority of inguinal hernias, so around 75% of abdominal wall hernias, are indirect inguinal hernias. Actually, direct, indirect, up to you how to pronounce. Let it be indirect inguinal hernias. These are congenital, of course, in origin, resulting from a persistent, patent processus vaginalis, an embryological outpouching of a peritoneum that accompanies, as you want, if you want, the testicles descent of the scrotum of the round ligament in females, or the round ligament in females, in ladies. So this patent pathway allows abdominal contents to protrude through the deep inguinal ring, lateral to the inferior epigastric vessels. So what's clinical importance of that? So knowing this is the most common type. Knowing this is the most common type overall helps prioritize differential diagnosis for a groin bulge, especially in younger individuals and children. So you will be asked about that, my beloveds. So anatomical landmark. Remember that indirect hernias pass through the deep inguinal ring lateral to the inferior epigastric artery vein. Direct inguinal hernias pass medial to these vessels through Hesselbach's triangle. A little bit later about this Hesselbach's triangle. So an exam question angle. A 5-year-old boy presents with a reducible groin swelling that increases with crying. What is the most likely diagnosis and its embryological basis? Your answer? Indirect inguinal hernia due to a patent processus vaginalis. Great. Femoral hernias, which protrude through the femoral canal inferior to the inguinal ligament and medial to the femoral vein, are much less common than inguinal hernias, 3% of all hernias, but are significantly more common in women. Female-male ratio approximately 4 to 1. Crucially, due to the narrow and rigid boundaries of the femoral canal, they have the highest rate of strangulation, up to 40%, among all hernia types, my beloveds. We will be asked about, of course it's a surgeon exam, but you will be asked about that. So, high strangulation risk. This high risk means femoral hernias generally warrant prompt surgical repair once diagnosed, even if asymptomatic. Diagnostic challenge: they can be small and easily missed or misdiagnosed as inguinal hernias or lymphadenopathy. A bulge below the inguinal ligament is a key. Exam question. Well, for example, a 65-year-old woman presents with acute groin pain at a tender irreducible bulge inferior to the inguinal ligament. What is the primary concern? Strangulated femoral hernia requiring urgent surgical intervention. That's it. Strangulation. Strangulation is a surgical emergency where the blood supply to the herniated contents, usually bowel, is compromised. No blood supply is compromised, that's why it's a strangulation. This leads to ischemia, necrosis, and potentially perforation. Unlike simple incarceration, where the hernia is irreducible but blood supply is intact, strangulation involves a vascular compromise. What's clinical importance of that? No, for exams. Urgent intervention. Signs of strangulation. Remember that, my beloveds. Erythema of overlying skin, fever, tachycardia, severe tenderness. What else? Symptoms of bowel obstruction. Like vomiting and obstipation, demand immediate surgical exploration and repair. Delay can lead to bowel resection, sepsis, and increased mortality, very high mortality. So differentiating incarceration versus strangulation, while both are serious, strangulation, of course, is life-threatening condition. Clinical suspicion is key. Labs might show leukocytosis or acidosis, or might show nothing. So exam question, simple. Describe the clinical features that differentiate the strangulated hernia from incarcerated hernia. An answer is, strangulation includes signs of ischemia, severe constant pain, tenderness, skin changes, you name it, systemic signs, like fever, tachycardia, so intoxication, and potential bowel obstruction, whereas incarceration is an irreducible hernia without these acute ischemic signs at all. Okay? Great. Now about this Hesselbach's triangle. So direct inguinal hernias protrude directly through a weakened posterior wall of the inguinal canal, specifically through Hesselbach's triangle. This anatomical triangle is bordered medially by the lateral edge of the rectus abdominis muscle, superlaterally by the inferior epigastric vessels, and inferiorly by the inguinal ligament. Okay, 3D. So once again, the anatomical triangle is bordered medially by the lateral edge of the rectus abdominis muscle, superiorly by the inferior epigastric vessels, and inferiorly by the inguinal ligament. These are typically acquired weakness. So clinical importance for exams, and not for only. So anatomical basics. Understanding Hesselbach's triangle is crucial for distinguishing direct from indirect inguinal hernias anatomically. So direct are medial to inferior epigastric vessels. Okay? Yes, risk factors. Often associated with conditions increasing intra-abdominal pressure over time, chronic cough, constipation, heavy lifting, and weakened abdominal musculature in older individuals. Exam question, simple. What are the anatomical boundaries of Hesselbach's triangle, and what type of hernia protrudes through it? Your answer is medial rectus abdominis, lateral edge. Superolateral inferior epigastric vessels, inferior inguinal ligament, direct inguinal hernias. Okay? Good. A Richter hernia, sometimes pronounced Richter hernia, up to you. So a Richter hernia, it's a dangerous and often deceptive type where only a part of circumference of the bowel wall, the antimesenteric side becomes incarcerated or even strangulated within the hernial sac. Clinical importance. Atypical presentation. Because the bowel lumen may not be fully obstructed, classic signs of bowel obstruction like obstipation might be absent, leading to a diagnostic and not very good delay. However, strangulation of that portion of the bowel wall can still occur rapidly, leading to gangrene and perforation. Any hernia site can occur in any, underline it, in any hernia type, but of course is more common in femoral and small incisional hernias. Okay, of course. Exam question sample. A patient with a known femoral hernia develops localized pain and tenderness but continues to pass flatus. What specific type of hernia complication should be considered? An answer is Richter's hernia, which can strangulate without causing complete bowel obstruction, my beloveds. Surgeon's signature. Incisional hernias develop, so incisional hernias post-operation, post-op, Incisional hernias develop at the site of previous surgical incision, sometimes months or even years after the operation. Yeah. They occur in up to 20% of abdominal surgeries, with risk factors including wound infection, obesity, malnutrition, smoking, immunosuppression, and surgical technique. No, for example, tension or closure. Clinical importance. Iatrogenic but common. A significant cause of patient morbidity and reoperation. Remember that, So that's why it's a surgeon's signature. Prevention and repair. Emphasis on good surgical technique and management of risk factors. Repair can be complex, often requiring mesh. We will little bit later about that. Mesh. No, that is hernioplasty, due to attenuated native tissue. Exam question type. List 3 patient-related risk factors for the development of incisional hernia. Easy peasy. Obesity, smoking, malnutrition, chronic cough, diabetes, immunosuppression, and so on. Spigelian hernias are rare hernias that occur through the Spigelian fascia, which is aponeurotic layer between the rectus abdominis muscle medially and the semilunar line laterally. They typically occur below the arcuate line where the posterior rectus sheath is absent. These hernias are often intraparietal, that is dissecting between muscle layers, making them difficult to palpate and diagnose. What's clinical importance of that? Diagnostic challenge. Patients may present with localized pain, often exacerbated by straining, but a distinct bulge may not be apparent. This can lead to delayed diagnosis. Imaging always needed. Ultrasound or computer tomography scan is frequently required for confirmation, but the most cheap, of course, ultrasound. High incarceration risk. Incarceration risk is high. Due to the firm fascial margins, Spigelian hernias have a relatively high risk of incarceration. An exam question type. A patient presents with localized right lower quadrant pain without a palpable mass, worsen tensioning abdominal muscles. Imaging reveals a fascial defect lateral to the rectus sheath. What type of hernia is suspected? Spigelian hernia. And what about umbilical hernias? Umbilical hernias present differently in children versus adults. In infants they are common, caused by incomplete closure or what? Of the umbilical ring, and most around 80-90% close spontaneously by age 4 or 5. Around 19, even more, 90%. In adults, umbilical hernias are usually acquired due to increased intra-abdominal pressure, for example, obesity, ascites, pregnancy, multiple pregnancies, and carry a high risk of incarceration and strangulation than in children. Clinical importance of that. Management differences. Pediatric umbilical hernias are often managed with watchful waiting. Adult umbilical hernias, especially if symptomatic or enlarging, are typically repaired surgically due to risk of complications. Associated conditions in adults look for underlying causes of increased intra-abdominal pressure, for example, ascites from liver cirrhosis. An exam question type. Contrast the typical management approach for an umbilical hernia in 1-year-old versus 50-year-old. An answer. Watchful waiting for the infant, likely to resolve spontaneously. Surgically repair often recommended for the adult due to the higher complication risk and unlikely spontaneous resolution. Yeah. While anatomical defects are necessary for hernia to occur, increased intra-abdominal pressure, IAP, increased abdominal pressure, is a major precipitating or exacerbating factor for most acquired hernias and can worsen congenital ones. This includes chronic coughing, for example, in chronic obstructive pulmonary disease, COPD. Normally it's a let it be COPD, chronic obstructive pulmonary disease. Benign prostatic hyperplasia causing straining, chronic constipation, and heavy lifting, obesity, pregnancy, and ascites. No clinical importance for that. Risk factor modification, identifying and managing these conditions can be crucial in preventing hernia formation or recurrence after repair. Preoperative optimization for elective hernia repair, optimizing conditions like chronic cough or constipation can improve surgical outcomes. And let's go exam question type. A patient undergoing elective inguinal hernia repair has a chronic cough due to smoking. Why is this this is a concern? Why is this a concern? An answer. Chronic cough increases intra-abdominal pressure, raising the risk of repair failure, recurrence, and post-operative complications like hematoma. Oh yeah. Good. Now, ancient dispute. Mesh or signature, or a suture, Mesh versus suture. The introduction of synthetic mesh for hernia repair, hernioplasty, for example, Liechtenstein repair for inguinal hernias, really revolutionized outcomes, significantly reducing recurrence rates compared to primary tissue approximation. For example, so-called herniorrhaphy, for example, Bassini, Schuldice. However, Schuldice or Schuldice, I don't remember. Bassini operation is one of the more procedure. Anyway, however, mesh is a foreign body and carries risks like a chronic pain, inguinodynia, so-called chronic pain, infection, and migration through. These are now relatively common. What is clinical importance of that, my beloveds? Standard of care, tension-free mesh repair. Now it's a standard for most adult inguinal and incisional hernias. Material choice. Understanding the benefits, lower recurrence, and potential drawbacks, mesh-related complications, is vital for patient counseling and managing post-operative issues. In contaminated fields, for example, strangulated hernia with bowel resection, surgeons may opt for biologic mesh or a primary suture repair to reduce infection risk. Logic. Fair enough. So, exam question is, what is the primary advantage of using mesh in inguinal hernia repair compared to a primary suture repair? And your answer is significantly lower recurrence rate due to a tension-free repair. So that's all. I clarified all misunderstood questions. Once again, actually, it's not first time that we used to talk about that. We are talking about abdominal hernias. It's, of course, for surgery exam. My beloveds, thanks for your attention. Don't forget to follow and subscribe my Dr. Y YouTube channel, as well as my private channel in Telegram, the same name, Dr. Y. So how to find this Dr. Y without question mark. Dr. Y, WHY, without exclamation mark, without question. How to find this Dr. Y in Telegram? You type in searching mode, in searching of Telegram, Dr. Y. It's a bot. You click start and you choose your plan. God bless.